Hello, everybody. Thank you so much for taking the time to attend our presentation concerning PDGM, or patient-driven grouping model for home health. Presenting today will be Karen Harnack. She's the RN case manager supervisor. Angela Borgman, RN clinical educator. She's also a case manager backup. And then myself as the director of quality. What we would like you to take away from this education are several things that we'd like you to be able to explain. One of them being the elements of the assessment that drive the ordered visit plans or visit frequencies, as you might recall. The importance of following those visit plans and what to do if you're not able to follow the visit plans. Where to find the elements of PDGM in the patient's chart. I'd like you to be able to explain 30-day periods of care, periods of payment. And then I'd like everybody to come up with a couple creative ways to deliver those visit plans in order to achieve goals and outcomes, achieve more with less, basically. And with that, I'm going to introduce our first speaker, which is Karen Harnack, and she's going to talk about overview of PDGM. Karen?
All right. Again, as Michelle said, PDGM is the patient-driven grouping model. This is actually how we get paid. Well, that didn't work out for me. Sorry, folks. These days, before with Medicare and VA, we would get paid for a 60-day episode, all encompassed. One 60-day episode, there was a RAP, meaning a request for anticipated payment at the beginning when we locked the OASIS and transmitted, and then a final payment, meaning we would get the remaining 40% of the payment when the discharge OASIS was transmitted to the state. Back then, the LUPA adjustment was always 5 visits. Of any sort of disciplines, it was 5 visits. You had to do 5 visits in order to not be paid per visit. This, with the PDGM, it's still a 60-day episode, but it remains divided now into 2 30-day periods. Each of these 30-day periods is also subject to a LUPA adjustment. The LUPA adjustment ranges anywhere from 2 to 6 visits in any 30-day period. The reimbursements now are divided into 4 smaller payments. So if the patient has visits in both 30-day periods, then each 30-day period will have a RAP and a final. There are also different LUPA thresholds in each of those 30 days. This is the worksheet that we use to prepare for in-case conference when you guys submit your OASISs and your evaluations. We look at the functional scores that were assessed by each clinician during the start of care or recert OASIS process. We review the OASIS, referral information, iterator forms, assessment summaries, assessment tools, and the SHP analysis. We then discuss any disparities with the scoring and come up with the most accurate OASIS score based on the information that we have. So if nursing puts something, that's what these numbers are. If nursing puts something down and therapy has something different, then we discuss which one best fits the patient. If we can't determine the most accurate score, then we will reach back out to the clinicians for clarification. Any changes to the any changes to the OASIS documentation must be approved by the assessing clinician. In this part of the in this part of the worksheet, I'm going to explain the other stuff that we use. We put down your wanted frequencies, your reason for home health, the goals that the patient wants to see for each discipline, whether it be nursing, PT, OT, or all of the above. The barriers for the patient that may keep them from or delay the positive outcomes. So it's very helpful if rationale and goals of the patient are included in the summaries as well as the barriers. The primary focus of each discipline regarding the plan of care. So we really take a look at the whole patient, the goals, the needs, and the abilities of each patient as seen through your eyes as the clinicians by reading the documentation. So although staying profitable is important to all of us, it is not all about the reimbursement, as you can see. In this part of the worksheet, this is the recommended visit plan. So when we enter the diagnoses and a HIPS code is generated, these are the recommended number of visits based on those HIPS codes. So you have skilled nurse or therapy only, and then you have a combination when multiple disciplines are ordered. Once the OASIS scores are finalized, coding's completed, conferencing completed, a score is generated by CanTime using this CMS algorithms, which is the HIPS score. That score is entered into the worksheet and a suggested number of visits per discipline is generated, and that is the suggested number right here for each 30 days. This is broken out into nursing only, therapy only, or combination scenarios for which specific visit counts are recommended. It's a starting point for the visit plan, and that is approved and keeping in mind any additional visits that may be requested. This is also discussed at length in determining a suitable frequency to utilize the number of visits recommended. Telehealth, social work, and home health aid visits are not calculated into the recommended visit scenario as they are not ordinarily requested. These are costs associated with care, so consideration must be given to the overall budget of the episode in determining adjustments in other discipline visit counts. Therapy consists of all disciplines, so your PT, your OT, your ST. The evaluations, visits, and the reassessments. When the approved visit plan is entered, the financial impact is displayed for us to be able to adjust the visit plan if needed. Patient-driven grouping model, early versus late, the timing. Early versus late on an OASIS M110, the first 30-day payment period is considered early if the patient has not been in a home health episode for greater than 60 days. When admitted for this episode, the second and all subsequent 30-day payment periods are considered late payment periods. This is why it's so important to ask if they have had any other home health in the last 60 days. If they have, be sure to alert the case manager to this. When is the last time a nurse or therapist came to your home is a great question to ask when you're doing your start of care. Your admission source, institutional. If the patient enters a 30-day payment period where they've previously been discharged from an acute or post-acute care facility within 14 days prior to the start of care of this 30-day payment period, the admission source is considered institutional. Acute or post-care, acute or post-acute facilities include skilled nursing facilities, long-term care hospitals, inpatient rehabs, acute care hospitals, or psychiatric facilities. Observation stays and emergency room visits do not constitute credit for an institutional referral. Following a transfer and hospitalization, the only facility considered as an institution is the acute care hospital. Community. If the patient has not been discharged from an acute or post-acute facility 14 days prior to the start of the 30-day payment period, the admission source is considered community. Make sure this is a question you are assessing for. Have you been discharged from any facility recently? Institutional scores more points toward the HIPS code. More points calculates to more visits. This slide simply illustrates the difference in reimbursement and therefore number of visits that can be done within budget between early and late episodes. All other variables are the same in the next few slides: the community, the grouping, the functional need, and the comorbidity. This slide illustrates the difference in reimbursement and therefore the number of visits that can be done within budget between institutional and community episodes. The group comes from diagnoses. The clinical group, this big orange box here, Clinical groups are intended to reflect the primary reason for a patient receiving home health. The groups are defined by the principal diagnosis as reported on the home health claim. There are 12 groups listed that are used. The comorbidity adjustment. The comorbidity adjustment is based on the secondary diagnosis as reported on the home health claim. You are an important factor in this staging, as you may not be the coder, but the coding staff needs the most accurate information in your documentation. So you need to be very, very clear of what is the most important diagnosis to provide the care for the patient's needs. Also, be sure to go back in to the episode tab to view the finalized diagnosis coding once you receive the message that coding is completed. This slide illustrates the difference in reimbursement and therefore number of visits that can be done within budget between a few diagnosis groupings to show the differences in reimbursement and visit plans suggested. So you see a wounds grouping, a complex nursing grouping, musculoskeletal rehab, and the difference in the visits that can be done just based on diagnoses. Based on the diagnosis as reported and coded, the patient will fall into one of these groups: none or low comorbidities, medium level of comorbidities, and high level of comorbidities that apply. This slide illustrates the difference in reimbursement and therefore the number of visits that can be done within budget between having comorbidities recognized and not. So in the low comorbidity, basically there's no CHF, diabetes, COPD listed as a secondary diagnosis. Here it just depends on what the comorbidity diagnosis is, and here again depends on what the comorbidity diagnosis is.
All right, thank you, Karen, for that great presentation. And next we'll have the functional part of the presentation.